Hello, folks. This is James, and today we're going to talk about primary polycythemia, which is a myeloproliferative neoplastic disorder that leads to an uncontrolled red blood cell production, platelets, as well as white blood cell count. So, not wasting much time, let's get started. But don't forget to hit the subscribe button. Erythropoietin receptor is a member of the cytokine receptor family that are expressed on erythroid precursor membrane. As you can see, they are also linked to a JAK2 tyrosine kinase. Erythropoietin receptor has the extracellular domain, the transmembrane domain, and the intracellular domain. It's very important because when erythropoietin binds to erythropoietin receptor, what happens is that JAK2 comes into close proximity with each other, and there is a phosphorylation process. JAK2 gets phosphorylated. Now, this is important. And then after the activated mode, what happens is there is phosphorylation downstream to the distal part of the cytosol or the cytoplasm. Here, it remains a docking site because there are other transcription factors such as STAT5. There can also be a phosphoinositol 3 kinase. These transcription factors can help with gene transcription, growth, and proliferation of the red blood cells. All right, so in majority of the patients, that is greater than 95% of the time, primary polycythemia is caused by a mutation in JAK2. Now, the mutation occurs at the position of V617F. This happens to be the most common form of mutation. However, other mutations may also be possible. This occurs actually as a result of valine to phenylalanine substitution. And when this occurs, this permanently turns on the signals in the erythropoietin receptor, even when circulating erythropoietin levels are low. So normally, there should also be a feedback mechanism to JAK so that JAK can inhibit itself through a dephosphorylation and can prevent the unregulated gene transcription. But in this case, the signals that is phosphorylation occurs downstream and leads to an unregulated gene transcription that causes excessive production of red blood cells, white blood cells, and of course, platelets. Hyperviscosity syndrome. What is the hemodynamic change that is going to be associated with hyperviscosity syndrome? Now, we do know that people with hyperviscosity will certainly have a high blood pressure. Let us take a look at some physiology. What I have here is a blood vessel with a length L, and the flow through this vessel is going to be represented as Q. The pressures between this point and that point I would represent as the mean pressure. And of course, this vessel would have a radius, which is going to be represented as R. So Mr. Poiseuille says that flow, that is Q, is directly proportional to the pressure, but inversely proportional to resistance. So we can then say that if you increase resistance, you certainly decrease flow. And this is what we see with hyperviscosity. The resistance is high, but then the flow is going to be low. Now, if you recall, I could say that flow, which is Q, is actually cardiac output because cardiac output is actually flow, right? Correct. So we can then replace cardiac output for Q and say that Q is cardiac output, and that is going to be equal to the change in the pressure divided by the resistance. And this is where we deducted our formula blood pressure. So the blood pressure, which is the change in the pressure right here, this is going to be our blood pressure. So I could then say that blood pressure is equal to the cardiac output multiplied by resistance. And what we are seeing in hyperviscosity is that this resistance here is quite high, and that is going to affect the blood pressure. That's going to make the blood pressure also high. But let us still proceed further to discuss some more physics and physiology. Now, you also realize that resistance is directly proportional to viscosity and the length of the vessel. and inversely proportional to the radius to the power 4. So when we talk about the radius, we're going to be talking about vasoconstriction and vasodilation. But here we are much more interested in the viscosity because we're discussing hyperviscosity. Now, if we should replace the formula down or we should put it into the formula up, then we could say that flow, which is Q, is equal to the change in the pressure divided by viscosity multiplied by the length of the vessel over radius to the power 4. Now we could flip this and make it even simple by saying that flow, which is Q, is equal to the change in pressure multiplied by radius to the power 4 divided by viscosity by the length. So this formula right here is very, very important, and I want you to take note of this. Now you realize that if you increase viscosity, you will decrease flow. Okay, and so this is what we are seeing with hyperviscosity, that the resistance is very high and that seems to increase the blood pressure. So this is not uncommon to see patients who have polycythemia, that is primary polycythemia or polycythemia in general, to have an increased blood pressure as a result of the increased resistance through the vessel. So very simple word to replace hyperviscosity is thick, and anything thick flows very badly and flows with quite some resistance. There could be some level of ischemia as a result of a poor perfusion of the brain, the heart, the lungs, the kidneys, as well as other vital organs in the body. Hyperviscosity would manifest with symptoms such as headaches, dizziness, vertigo, tinnitus, visual impairment, chest pain from angina, intermittent claudication, Raynaud's disease, retinal impairment, and hypertension. Pruritus, itching of the body. It is quite common to have patients with primary polycythemia to complain of itch after taking a hot shower. This is actually because of the increased histamine release from basophils and mast cells, as you recall that primary polycythemia is a myeloproliferative disease. Plethora, a reddish or ruddy color due to increased red blood cell mass, is often seen in the face, palms, conjunctiva, and mucosa. Peptic ulcer disease may be associated with primary polycythemia as a result of an increased histamine and gastric acidity. Primary polycythemia is a myeloproliferative disorder that does not only increase the red blood cell mass but also causes thrombocytosis and an elevated white blood cell count. Another factor to note is an increased tissue factor synthesis by the elevated leukocytes in myeloproliferative diseases, which can activate the extrinsic pathway in the coagulation cascade. So, generally, this will lead to stasis and a hyperviscosity syndrome, which is a risk factor for not only arterial thrombosis that may cause stroke, myocardial infarction, or a peripheral vascular disease, but also a venous thrombosis, such as a deep vein thrombosis or hepatic portal vein thrombosis, as in Budd-Chiari syndrome. It is important to note that thrombosis is a major cause of mortality in patients with primary polycythemia. Erythromelalgia may also be associated with primary polycythemia, and this is characterized by an intense burning pain, erythema, as well as an increase in skin temperature of the affected extremity. Primary polycythemia as a myeloproliferative disorder may cause splenomegaly or hepatosplenomegaly. Now, patients with primary polycythemia may also have bleeding from superficial structures. This may not be entirely clear, but the membrane of the excessive platelets can soak up all the von Willebrand factor multimers and predispose to acquired deficiency. This would lead to a bleeding time prolongation as well as a PTT time prolongation. The reason for PTT time being prolonged is because von Willebrand factor protects factor 8 from degradation. So when there is less von Willebrand factor, this would lead to factor 8 also being degraded, and of course, that will certainly lead to an increase or prolongation of PTT time. A high cell turnover may also cause metabolic impairment such as hyperuricemia, which predisposes to gout and renal stones. Patients may also report sweating excessively, especially at night. Diagnostics. So the major WHO criteria state as follows. hemoglobin greater than 16.5 gram per deciliter in men and greater than 16 gram per deciliter in women, or hematocrit greater than 49% in men and greater than 48% in women, or a red cell mass greater than 25% above mean normal predicted value. Bone marrow biopsy showing a hypercellularity with panmyelosis, that is an increase in all three cell lineage, and of course the presence of a JAK2 V61F domain mutation or a JAK2 exon 12 mutation. And the minor WHO criteria states that the serum erythropoietin level should be below the reference range for normal. Now let us take a look at some important factors that is necessary to consider when it comes to primary polycythemia. The red blood cell morphology is normal. Platelets, leukocytes, and basophils as well as eosinophils are elevated as this is a myeloproliferative disorder. Increased vitamin B12 levels may also be seen as a result of the elevated transcobalamin, which is produced by the excessive white blood cells. Uric acids may be elevated, which can predispose to gout or renal stones. A biopsy may show myelofibrosis in the spent phase. It may also show an acute myeloid leukemia. So there is a risk for leukemia, hence, there is the need to monitor with a complete blood count every 3 months. Iron levels may also be decreased as the excessive red blood cells would make use of the iron. Treatment. A general management option includes phlebotomy every week until hematocrit is less than 45%, and this has been shown to decrease the thrombotic events. A low dose aspirin is also recommended. Antihistamine may also be given for the pruritus. Allopurinol or febuxostat may also be used if there is hyperuricemia. Management options in high risk patients. So, the first line choice that may be adopted would be a hydroxycarbamide or preferably a pegylated interferon. If you choose to use hydroxycarbamide as first line, then your second line becomes a pegylated interferon, and vice versa. In case you have a patient that is intolerant or resistant to hydroxycarbamide, then ruxolitinib, which is a tyrosine kinase inhibitor, may also be used. Now, third line agents may include busulfan, which is an alkylating agent. It has been associated with leukemia. There is also phosphorus 32 or piperbromine, and these agents may be used if there is a limited life expectancy. Thank you, and I hope this was useful. If you enjoyed it, then hit the like button and subscribe to the channel. Bye.